In 1916, three French physicians, Georges Guillain, Jean-Alexandre Barré, and André Strohl, published a paper that came to define an old disease and eventually gave it a name. Describing this in their book titled Guillain-Barre Syndrome From Diagnosis to Recovery, Gareth, Parry, and Joel Steinberg wrote that the 1916 observation and description by Guillain, Barré, and Strohl of what they call radiculoneuritis with hyperalbuminosis of the cerebrospinal fluid without cellular reaction was truly original. Parry and Steinberg explained that the three French physicians significantly noted that the protein in the cerebrospinal fluid was increased, that's hyperalbuminosis, and there was no increase in the number of white blood cells. And this helped to distinguish the disorder from polio, what they said was the most common cause of acute weakness at the time, and a disorder that was known to cause increased numbers of white blood cells in the CSF. It was mainly their identification of the CSF peculiarity that Parry and Steinberg said led two influential French neurologists, Draganescu and Claudien, to designate the disorder Guillain-Barre Syndrome in 1927. Hello, I'm Ibrahim Imam, and welcome to this episode of the Neurology Lounge podcast, which will be exploring the condition simply known as GBS. I am perhaps jumping the gun a bit, so let's take a step back from the cerebrospinal fluid and first see how GBS manifests. And we will start with the story of Meg Lumsden, who narrated her illness in the memoir titled Unknown. Lumsden and her partner Tim were on a tour of Vietnam, Laos, Cambodia, and Thailand with a group when she said she developed a creeping nausea and a mild fatigue. She initially attributed this to their long day in the sun. Lumsden wrote that the best way I can explain it is to say that when I was standing still, I felt like I was still moving. She then started sweating profusely and her vision suddenly became foggy, as if she was trying to see underwater. All the while, she said her head was spinning furiously and her stomach was churning. She then said a sensation of pins and needles shot through her body like wildfire, beginning from the tips of her toes and fingers. She said, "It was as if my nerves and veins were wires in an electric circuit. My face grew numb. My ribs stopped expanding and I struggled to breathe." And then she lost bladder and bowel continence. On testing herself, she found that she could just wiggle the fingers on her left hand, but could not squeeze them or make a fist. She added that her right arm and both legs felt like they were being crushed, and she was referring to this pain as being unbearable. She also perceived a weird numbness as if she had no limbs. And when she tried to move her body, she said everything from my neck down was not responding. The doctors who assessed Lumsden quickly concluded that she was suffering from Guillain-Barre Syndrome. Before looking into what GBS is, let us explore another example of the disease, one that was narrated by Simon Smith in his memoir titled What Guillain-Barre Syndrome Did to Me. Smith's illness started with indigestion-like chest pains, what he referred to as a new level of pain and discomfort. He then developed long stretching aches in his legs and arms, which made it difficult or impossible to sleep and impossible to lie comfortably. His legs then went all funny with a strange tingling on the top of his left leg. And as his dead cold feet ached and stung, he said the pains took his breath away. His walking became unsteady, with his left leg wobbling and spasming, and repeatedly giving way, leading to falls. Eventually, his bladder function became impaired, requiring a catheter. Smith also narrated the clinical signs the doctors elicited when they examined him. For example, he said he had total areflexia, the absence of any neurologic reflexes, and he had no plantar responses, referring to how his toes did not move when the sole of his feet was scraped or stroked. The cases of Lumsden and Smith illustrate the typical ways in which Guillain-Barre syndrome presents. The cardinal features are progressive weakness, mainly involving the proximal or upper parts of the limbs, severe fatigue, and autonomic dysfunction with such impairments as those of bowel and bladder functions. And as demonstrated by Smith's case, reduced limb tone and reduced or absent reflexes are the classical findings in GBS. These may, however, be absent, especially in the early course of the disease. As we have seen in all the preceding narratives, pain is a frequent feature of GBS, although often poorly appreciated and remarkably underestimated. A memoir that explored the impact of pain in GBS most graphically is that of Carol Williams, titled Chaos in Body and Mind. Indeed, the earliest symptoms of GBS that Williams experienced were twinges of pain that she said needled my lower back and behind both knees. By the second day of her illness, she said this had evolved into a persistent dull pain in her bones and evolving to become a generalized pain almost everywhere that weighed her down. Over the next 2 days, she said the pain throbbed deeper in every bone and grew more intense. It was when the pain became unbearable and unrelenting that she got her husband, Stuart, to take her to the emergency department. And it was only after this that she noticed muscle weakness, which made her shuffle on walking and eventually falling when her legs became paralyzed. And it was after this that she developed tingling in the fingers, weakening of grip power, loss of reflexes, facial weakness, impairment of speech, and breathing difficulty, which required a ventilator. And through all this, she said that the unbearable pain persisted. She said every bone throbbed like an infected tooth, and she could not stand the slightest touch of her skin. Even when she returned to work after discharge, she said her days were interrupted by pain and exhaustion. She said GBS left me with chronic pain that lurked at every meeting where I needed to pay close attention and under the desk when I was trying to compose a complicated report. The rapidity of progression of GBS can sometimes be astonishing, and this was illustrated by Philip Taylor in his illness memoir titled Going Full Circle, My Fight Against Guillain-Barre Syndrome. Taylor was 39 years old when his illness started, with him feeling a bit rough. He said, my arms felt really stiff and heavy, not unlike the feeling you sometimes get after a good session in the gym. I won't be able to tell. He also developed shooting pains in the soles of his feet, which occasionally made him jump. By the following day, Taylor said, I couldn't raise my arms much above shoulder height. Later that day, he said, my arms were so weak that I couldn't even muster the relatively small amount of pressure that was needed to depress the springs on my wood router. Whilst in hospital, he said he was shocked by how fast his leg weakness developed. In the space of just a week, he said, I had lost virtually all my arm movement, and now it looked like my legs were going the same way. The most concerning manifestation of GBS is when it progresses to respiratory difficulty, and this is graphically illustrated by Smith's illness course. For example, he wrote that as his illness progressed, breathing in became such hard work, and it came along with difficulty coughing to clear his chest. The effort of breathing eventually exhausted him, and he required oxygen and eventually a ventilator. The emotional dimensions of GBS also come through in the illness narratives of GBS as narrated by Robin Shepherd in his memoir titled A Solitary Confinement. Shepherd's illness started with a stabbing pain in his back and pins and needles and numbness in his stomach and a heaviness in his arms and legs. His illness progressed rapidly until he said ordinary, everyday events like blowing my nose or picking up a telephone became monumental tasks. His breathing then became irregular and he felt intermittently faint, and the balance between talking and inhaling air grew more tenuous. By the end of that day, he said he was completely and utterly immobile. Referring to his sense of helplessness as all-engulfing, Shepherd regretted that whatever my dignity used to be no longer is. It is deceased. He also discussed the depression that followed, referring to this as an almost inevitable consequence of GBS. The clinical manifestations of GBS may be triggered by an illness in the preceding 2 to 3 weeks, and this is comprehensively portrayed by Scott Earle's memoir titled The Wave of Guillain-Barre Syndrome. Earle wrote that his illness started after returning from an Easter surfing break that he had taken with his wife Bryony and newborn baby girl Miller. In the first week of returning, he said he had a head cold which came with aches and pains and symptoms more like a flu, and he felt lethargic and tired. Despite 2 courses of antibiotics from his doctor, he said, my symptoms persisted and I felt no better. It was by the time of his second visit to the doctors that he developed the early symptoms of GBS, which he said were slight tingling sensations in his hands and feet. This was followed by poor balance and falls, and by the time he went to the hospital, he said, I could barely walk. Another memoir that highlighted the prodromal illness that can precede GBS is that of Wednesday Ketron, titled Gian What? My Guillain-Barre Syndrome Survival Story. Her GBS had manifested with profound weakness, numbness, and tingling in the limbs, and unsteadiness, and all this developed at a concert that she had attended with her husband and daughter. But before then, she said, I had had a stomach bug keeping me close to the bathroom for 8 days. She added that I had never had diarrhea last that long, and this was shortly accompanied by vomiting. Taylor also had a preceding illness before his GBS emerged. Whilst he himself had forgotten about it when his doctors were asking him, and he said they were asking him all manner of sometimes rather worrying questions, this included whether he had flu, diarrhea, sicknesses, or whether he had used toxic substances. It was his wife Linda who remembered that the week before he fell ill, he had suddenly developed awful diarrhea. The list of infections that can trigger GBS is almost endless. But at the top is Campylobacter jejuni, a bacterium that causes a diarrheal illness. Other top infectious triggers are viruses such as CMV, EBV, and HIV, and such bacterial infections as brucellosis and Lyme disease. And apart from infections, GBS may also be sparked off by a wide range of non-infectious triggers which include vaccinations, such as those for influenza, rabies, and polio, as well as autoimmune disorders such as systemic lupus erythematosus or SLE, sarcoidosis, and Crohn's disease. There's also a miscellaneous group of triggers which include trauma, surgery, and childbirth. Beyond the classical manifestations of GBS we have so far seen, the illness may also present with a diverse range of very unusual symptoms. Take the case of Ketron, for example, who reported that right from the onset, her mouth tasted like a dirty copper penny. This yucky metallic taste persisted through her illness, and she said no amount of brushing, eating, or drinking relieved it. She added that the taste made everything, even water, truly disgusting. And when she tried to eat a piece of bread, she said, I had a mouth full of tiny pieces of cotton that tasted like metal. I couldn't swallow it. I spat it into a napkin. Apart from the impairment of the sense of taste, GBS may also manifest with loss of hearing, vocal cord paralysis, and bulging eyes, also called exophthalmos. And more peripherally, other unusual features of GBS include headache and muscle twitching. Unlike in Lumsden's case, where her doctors honed in on the correct diagnosis rather promptly, Smith's doctors did not initially consider Guillain-Barre syndrome, and although his brother's friend had suspected that he may have GBS, his doctors did not consider this as likely until much later on. And the reason for the difficulty in making an early diagnosis of GBS are the number of disorders that can mimic it. And amongst the top mimics of GBS is Lyme disease, one of the disorders that Smith's doctors explored very early on in hospital. Other infections that cause neuropathies that can mimic GBS include West Nile virus, botulism, HIV, and enterovirus D68. The range of other neuropathies that can mimic GBS include CIDP, considered to be the chronic form of Guillain-Barre syndrome, critical illness, and paraneoplastic neuropathy. Other neuropathies mimic GBS by also causing demyelination or loss of the fatty layer covering the nerves. And these include neuropathies caused by tetanus toxoid, the drug called nivolumab, and by PEG interferon. Finally, non-neuropathies can mimic GBS, and these include a condition called periodic paralysis, as well as myasthenia gravis, inflammatory myopathy, and acute myelitis, as can occur in the early stages of multiple sclerosis. Recovery from GBS varies widely between patients. In Lumsden's case, she said the first significant turning point was on the 9th day when she noticed definite signs of improvement. She wrote that she began to breathe without discomfort, and she felt her strength slowly returning, starting in her hands. And by the 12th day, she said she was strong enough to sit upright in a chair for the short journey to the treatment room, although her legs had to be lifted onto the foot pedals. Her condition gradually improved over the following 3 weeks, but she said it required sustained rehabilitation over several months. Smith's recovery also took months, during which he said his feet got some of their feeling back, his walking became stronger, and the stings lessened. All these enabling him to restart his indoor hobbies. It was, however, a year before Smith said he left the house on foot. Shepherd similarly required hospital care for 10 months, and even a year after discharge, he said, I can only manage to undo shoelaces but can't do them up. I can put food in my mouth with a spoon but can't cut it with a knife. I can undo some buttons on my shirt but can't get my left arm into the sleeve or do any buttons up. My gait resembles the Tin Man from The Wizard of Oz. This is perhaps a good time to go back to basics and ask what is really going on in the nerves in GBS. GBS is caused by an autoimmune attack on the fatty myelin layer that protects the nerves and that enables them to conduct electric impulses much faster than if they were not so covered. And the conventional antibodies that cause the damage are called antiganglioside antibodies, and these have such subtypes as anti-GM1 and anti-GQ1B. The latter is more often the cause of a variant of GBS called Miller-Fisher syndrome. More recently, another group of antibodies that can cause GBS have been identified. These so-called paranodal antibodies include neurophacin 155 or NF155, contactin 1, and Caspar-1. The investigation of GBS, therefore, frequently includes a search for the triggering infections and the provoking antibodies. But more important in the investigation of GBS is a lumbar puncture or spinal tap. This is a test that Lumsden, Smith, and Taylor all had, and it is almost indispensable in the diagnosis of GBS because the results are most helpful in confirming the diagnosis. And as we have seen, the finding that is most suggestive of GBS is called albuminocytologic dissociation. It's not too complicated. This is the presence of a very high protein level in the spinal fluid, but with a disproportionately low white cell count. Another helpful test is the nerve conduction study, and this is a test that helps to show that the neuropathy is demyelinating rather than axonal. Axonal means it's the nerve fiber itself that is damaged. And for the neurologically inclined, the tester is looking for absent or prolonged F waves and looking for something called conduction block. The nerve conduction study may, however, be normal or equivocal, especially in the early disease course. That is also the case with this lumbar puncture. Other tests that may be considered in GBS include magnetic resonance imaging, which may show enhancement or lightening up of the spinal roots when a dye or contrast is injected during the imaging. And the major treatment of GBS is aimed at correcting the overreacting immune system, and there are different approaches to this. Lumsden, for example, underwent plasmapheresis or plasma exchange, a technique that literally washes out the offending antibodies from the blood. Smith, Earle, and Taylor, on the other hand, were treated with intravenous immunoglobulins or IVIG. Taylor referred to IVIG as a strange viscous fluid that would either go all bubbly in the bottle or allow air into the feed tube, setting off the alarm almost constantly. Unlike plasmapheresis that removes the antibodies, IVIG binds and neutralizes them. To explore the clinical perspective of GBS further, I will be speaking to Holly Francis, author of Life Support, in the next podcast. Thank you so much for listening or watching the podcast in which we explored Guillain-Barre Syndrome. If you found the podcast enlightening, you may consider subscribing to the Neuro Checklist website, which has a lot more information about GBS, or you may read my book called Surfing the Brain for a Light Touch Neurology. And to make sure you don't miss the next episode of the podcast, why not subscribe to the Spotify or YouTube channels to catch me when I'm in conversation with Holly Francis. Thank you very much for your time.